Welcome, all of you. This is our panel. Actually, Rakesh, why don't you introduce them here and their topic, and then I'm going to kind of take us off the screen and let them have the conversation for a little bit. Before you introduce, I do want to remind people who are listening, please submit the comments, questions for our panelists into the stream here, and we'll share them up with them so they can attempt to answer them, or maybe look at them after the whole experience. So thank you. Rakesh, go ahead.
Thank you. I know Abhijit since my fellowship days in Canada. Abhijit is a pediatric regional anesthesiologist from London, Ontario. He did his fellowships in Toronto Western, SickKids. Am I right?
Yep.
And he can do the introductions for the rest of the panel. Stephanie is my colleague from Stanford.
Thanks, Rakesh and Raj, and thanks for inviting us to speak in this session. This is going to be a panel discussion, more of an interactive session. Before we go ahead, I would like to introduce my colleagues, esteemed speaker from different part of the US. So I have Dr. Stephanie Spahn. She's an associate professor at Stanford University of School of Medicine. Then we have Dr. Rani Sundar, associate professor, Department of Anesthesiology and Pain Medicine, Seattle Children's Hospital and University of Michigan or Washington School of Medicine. And lastly, we have Dr. Vipin Bansal, assistant professor, Department of Anesthesiology, Emory School of Medicine. And I'm Dr. Abhijit Biswas, associate professor, Department of Anesthesia, Pediatric Medicine at Western University, Canada. Now, our topic today is an interactive session on innovations in the world of pediatric anesthesia, regional anesthesia, and pain medicine. But before we go ahead on what we are now, I want to share briefly regarding how we started and when we started, how we started, where we started, before we go to know what we're doing now. Again, in brief, the journey of regional anesthesia began as early as 1884 with Carl Core, discovery of the local anesthetic properties of cocaine when used in the eyes. Following which, like after 14 years, August Bayer performed the first spinal anesthetics using cocaine in 6 patients. 2 of them were children. All of them had severe headache and nausea, vomiting. And then he tried on his own, on himself and his assistant also the following day. And with a similar problem, they stopped the whole thing. It took at least a decade before the whole spinal anesthetic came into work again. And from early 90s to late 90s, there was a lot of change. We had anesthesiologists introduced at doing anesthesia, not the surgeons. Local anesthetic changes and way of doing the spinal, everything changes. I'm from Canada. The first reported pediatric patient getting a spinal was in 1933 in Toronto and 1949 in Montreal. In the same year, 1933, the first use of caudal analgesia for cystoscopy was described by Meredith Campbell in the American Society of Regional Anesthesia. Now, thus goes a bit of brief history of how we started, when we started. Since then, things have changed a lot. Lots of evidence for pediatrics, change of local anesthetics, ultrasound, neuromodulation in pain. There's so many things to talk about. So before I go ahead and start anything more, I would like to invite Stephanie and discuss a bit more about what we have changed over the safety over the years in safety in pediatric regional anesthesia.
Thanks so much, Abhijit, especially for the introduction. It's really wonderful to see everyone. This is a huge question. So I like to break it down into really like 4 main factors. And just as an intro, pediatric regional anesthesia has really undergone a profound transformation over the past several decades. It was once viewed as maybe like a technically challenging, really like potentially high risk technique, but it's since evolved into something that's really a cornerstone of modern pediatric anesthesia practice that we use every day. So these 4 converging factors that I personally think have been really the main drivers for improving safety standards is really advances in understanding the anatomy of pediatric patients and anatomy advances in imaging technology, pharmacology, and really overall safety-focused hospital and institutional practices. So at least let me first start off with the understanding of advances in anatomy. So if we look back, early pediatric regional techniques were really largely extrapolated from adult patients, despite knowing that there are developmental differences. We really now recognize that children are simply not just small adults or tiny humans. There are key differences. So things like a more superficial neuraxis, lower termination of the spinal cord, especially in infants and neonates, and incomplete myelination. These really affect block placement and local anesthetic spread. An improved pediatric anatomical understanding has allowed clinicians to refine their needle depth, landmarks, and expectations of block behavior. And even with these like basic understandings of like foundational anatomy, we still have instances where we're a bit caught off guard or surprised when a block doesn't quite behave what we expect it to. And that's very normal. And I think that's a great way for us to keep expanding our knowledge of pediatric regional anesthesia. But overall, I think the improved understanding reduces the risk of technical failure and neurologic risk. So that's just the first factor. The second factor is the advent of ultrasound imaging. And just like adults, this is a really important advance in pediatric regional anesthesia. Previously, landmark-based and nerve stimulation techniques were quite limited, especially in pediatric patients because of their smaller size, their inability to really communicate, especially under general anesthesia. As we all know, ultrasound has really allowed us to see in real time visualization of nerves, adjacent structures, needle trajectory, and even local anesthetic spread. But this is even more important in pediatric patients because it allows us now to routinely perform blocks under general anesthesia. And what this means is it results in a far less traumatic experience for our pediatric patients. And if we think about it, for everyone involved in the room, adults included. So with ultrasound, it also leads to a higher success rate for blocks, a lower volume of local anesthetic, and really fewer complications such as intravascular injections and pneumothoraces. Imaging has also allowed for us to really adopt more fascial plane blocks, which I think Rani will get into later. But I'm going to pull it back to the third factor that has really led to safety in pediatric regional anesthesia, which is advances in pharmacology and dosing strategies. Historically, dosing was really conservative and inconsistent, really driven by the fear that we would have local anesthetic systemic toxicity in kids, also known as LAST. Over time, pharmacokinetic studies have really clarified age-dependent differences in protein binding, in hepatic metabolism, and cardiac sensitivity. This has led to weight-based and age-adjusted maximum dosing guidelines, rather than just simple adult extrapolation. The introduction of longer-acting agents like bupivacaine, levobupivacaine have led to less cardiotoxicity, and then adjuncts like clonidine and dexmedetomidine have further extended analgesia while allowing for lower local anesthetic doses. And then finally, the fourth component of this really long question for safety standards in peds regional anesthesia is really that safety practices in pediatric regional anesthesia have evolved from kind of individual caution to a more system level safeguard. So things like standardized dosing charts, color-coded syringes, ultrasound-guided injections, mandatory aspiration and incremental injection, and even the use of like hydrodissection really allow us to target where our local anesthetic is administered and how much we give. Another component of this is the use of large registry data. And a huge example of this is the Pediatric Regional Anesthesia Network, also known as PRAN. So PRAN demonstrated that complication rates are low when blocks are performed with modern techniques. So with all this combined with improved imaging, dosing precision, really the complications that we've seen in these databases are fairly minor now and mostly transient. So things like catheter dislodgement or incomplete blocks show up way more rather than the more like catastrophic neurologic or cardiovascular collapse. I think this shift really reflects better technology, databases, but also we should give ourselves some credit for it too, in that it also reflects better training, fellowships, documentation, and quality improvements within our individual hospital systems and on a nationwide system. So in conclusion, I think there are four main driving factors for safety within pediatric regional anesthesia. These include advances in anatomical knowledge, really providing that foundation. And then on top of that, imaging, bringing more precision, pharmacology with more larger safety margins, and then evolving standards that have been embedded within our safety culture for routine practice. And with these developments together, they've really transformed pediatric regional anesthesia from what we may occasionally consider as a high-risk adjunct before into something that's more of a core component of safe, effective, and opioid-sparing perioperative care for the children that we take care of every day. So, thanks.
Thanks, Stephanie. That's really good. I know I gave you a very large topic to discuss in 5 minutes, but I think you did a very nice job. I have a next question coming for Rani. Like nowadays, fascial plane block, like any truncal surgery you do, fascial plane block is a part of a multimodal. It's become a fashion in adults and peds as well. And we have come a long way in fascial plane block, and every month there's a block coming up. Do you have any updates on fascial plane block in pediatrics or any innovation that you know and we can share with us, please?
Yeah, thank you for that question, Abhijit, and welcome everybody. It's true that we are moving away from neuraxial blocks in pediatrics in a big way. And a small example for this is the caudal block, which was the most frequently performed block by pediatric anesthesiologists worldwide, has slowly come down. And we have newer blocks that are used. Those are called fascial plane blocks that are used for commonly performed procedures in pediatrics. Like you have inguinal hernia now mostly performed using ilioinguinal blocks, urethroplasties, which were again a common indication for caudal blocks, are now mostly performed under pudendal blocks. These blocks have the advantage of lasting longer than traditional neuraxial blocks, and the advantage of staying away from the neuraxis, which comes with its own set of complications and safety data. So the evolution of fascial plane blocks in pediatrics has pretty much run parallel to the adult world. We've adopted most of the blocks that have been described in the adult world in pediatrics and found uses unique to pediatric practice. As Stephanie pointed out, that ultrasound has been a big catalyst for development of new blocks. To name a few, erector spinae block, which is now found to be a great alternative to thoracic epidurals for thoracotomies and other such procedures for the chest wall. Serratus plane blocks and transversus thoracis muscle plane blocks. In our practice, we use it a lot for placing vagal nerve stimulators, AICDs in patients for chest wall procedures, some thoracotomies, rib fractures, and such like. External oblique intercostal plane block in pediatrics, especially in my practice, it's a great alternative to provide good quality analgesia to kids getting G tubes, open G tubes placed. And you know that this patient population is very vulnerable with multiple comorbidities that make opiates kind of restrict the use of opiates in these patients. PENG blocks for both hip and shoulders. We've been using them a lot for hip arthroscopies and shoulder arthroscopies. So the list is long, but I'm going to restrict myself to these new blocks that we've used. And pudendal block is now kind of old. That is, again, one of the commonest fascial plane blocks that we use in pediatric practice. A point that I would like to make here now, that aside from the major gain of discovering new blocks, it is in the improvement of safety and efficacy data that Stephanie also mentioned that can be attributed to ultrasound guidance in fascial plane blocks. We've moved away from the age-old technique of pops to visualize local anesthetic blooms and unzippering of fascial planes. So this helps in improving block metrics. You have the needle in the correct place. You're opening up the correct plane. So we get a better quality of block. We reduce trauma to adjacent tissues and vascular structures. Going back to the question about dosage, targeted ultrasound guidance has helped decrease minimum anesthetic volumes and minimum required anesthetic concentrations for targeted nerve blocks. However, the difference in fascial plane blocks, because they are volume dependent, that is, a fascial plane blocks requires the local anesthetic to block dispersed nerves or possibly create a pressure head so that the drug volume can travel to a site adjacent to the site of local deposit so that it can provide its or produce its action of anesthesia and analgesia. So, and the volumes can be as high as 0.5 ml per kilo. So we technically cannot reduce the volume in fascial plane blocks as they are volume dependent. So in our practice, we want to be careful, especially as pediatric anesthesiologists. We deal with patients who might range in weight from 5 kilos to 105 kilos. That is imperative to practice weight-based dosing. And I would like to make a push here for using either ideal body weight or corrected body weight for dosing local anesthetics. Lastly, in pediatric practice, age-dependent variations to fascial plane blocks can affect block metrics. For example, in younger children, the connective tissue is known to be looser and more elastic. So this could be advantageous to a pediatric anesthesiologist as we can unzipper fascial planes better. So we get better quality of fascial plane blocks in younger children. Especially this has been demonstrated in erector spinae blocks. However, on the flip side, in very young children, and with the limitation of block needles that are available to us, especially the bevels of the needle can slip in and out of fascial planes, kind of reducing the exactness of the local anesthetic deposits in fascial planes. But this can be forgiving because the thin fascial tissues allow for diffusion into the desired planes. So there is both the yin and yang of doing these blocks in pediatrics. And moving on to fascial plane catheters, I can say that the winds of change
Rani,
are
before
blowing.
you go ahead, I just want to add on one comment to that. And
Yeah.
recently in my practice, as you rightly said, the bevel end of the thickened needle, it causes a bit of problem approaching the fascial plane, especially in like few months old kids. It's really difficult. So what I have changed my practice a bit. What I do is I use a single shot needle to open up the space, inject the volume, and then I use a Tuhi needle to go to the space because the space is now already filled up with the volume, and I have a lot like it's easy, way easier now to place the catheter and find the space. So this is a bit of change I have done in my practice, and
Yeah,
it
that's
looks
a
like I'm
great
very successful. Yeah.
That's a great tip. And what I all practice and I teach my fellows and residents is that you open up a plane and you always advance a needle in the local anesthetic volume or in that instead of trying to advance to the corner of the fascial plane. So traveling in a puddle is safer than trying to, open
Yeah.
up a fascial plane directly. I'm going to finish up by talking about fascial plane catheters and protocols that are evolving. And very briefly, I can say that the winds of change are blowing. And there is an interest in programmed intermittent bolus regimens for fascial block catheters. Perhaps Stephanie can speak to that later because her institute, I believe, has moved towards programmed intermittent bolus regimens for all fascial plane catheters. The advantages cited are decreased hourly dosage of local anesthetic. That means it increases safety and better analgesia as mechanics of fascial plane blocks require larger larger volumes and a pressure head to facilitate the flow of local anesthetic to the target area. So think about erector spinae block, where you need for the local to travel to a different target area, or in case of a lumbar plexus block, which is again a fascial plane block in the psoas muscle compartment where the nerves are widely dispersed, or in a tap block where the nerves are widely dispersed, that once you have a large volume and a pressure head to drive the local anesthetic towards these the targets, the quality of block would be better, and you would have better patient satisfaction. So this is where I would conclude about fascial plane blocks and the evolution in pediatric practice.
Hey, thanks a lot, Rani. That was really informative. Stephanie, do you want to comment a bit on the program intermittent bolus? Actually, it's a work in progress in my institution. I'm trying to get that for pediatric and adult as well. Maybe in another 6 months or something like that. But yeah, please.
Sure. At Stanford or Lucille Packard Children's Hospital, for a lot of fascial plane blocks, we use a hourly or actually an intermittent bolus, depending on what medication we use, whether it's like chloroprocaine for our younger children or ropivacaine. We found that it just opens up the space a lot more because a fascial plane block is volume dependent. And then once you have the local anesthetic in that fascial plane, it has a half-life, and so it doesn't need a continuous infusion throughout that entire specified hour or whatever time frame that you're using. And we found kind of better analgesic effectiveness as opposed to the alternative, which might be a continuous or lower dose infusion over that same period of time.
And I will add to this by saying that we recently published studies in population pharmacokinetics in the lumbar plexus region, and we found that you could actually increase your hourly volume times 3, so 0.6 ml per kilo per hour per bolus, and keep the maximum dose to almost 1/3 the hourly infusion rate. That is, you increase the safety metrics by 3-fold.
Amazing. Thanks so much. Okay, and lastly, we have Vipin. There's so much happening in the world of pediatric chronic pain.
So,
Bioablation, neuromodulation. Okay, the stage is yours.
all right. Thank you for having me. Thank you for inviting me, Abhijit. And I want to thank all the speakers in my group as well as the other groups. And I will start with saying,
Vipin, please unmute yourself.
I'm not mute or.
No, I can hear you.
Okay. The rest of you guys, can you hear me, Raj?
Yeah, I can hear you. Some people have had audio issues where they can't hear one or two of the speakers. I'm not sure what's happening,
Okay.
but your audio is coming through.
Okay, it's coming through okay?
Yeah.
All right. I was going to answer that. Ed Mariano asked me a question. I've been doing regional anesthesia for the last 10 to 15 years. I love it. I love doing nerve blocks. It's amazing. You can really fix acute pain. But can you fix chronic pain with that? And what excites me now is neuromodulation. You can use neuromodulation to fix acute on chronic pain. And my specialty or my focus has been helping kids with amputation pain. That's, a tragedy that we haven't done a lot with. I've tried single shot blocks. It doesn't work. You need something long acting. I've used catheters. To me, catheters can work, but they have to be at least 5 to 10 days where you see treatment, where you can help the kids with residual pain and phantom pain. But as you know, there's a lot of times when these kids come in, their trauma, their lawnmower accidents, their MVCs, and I hate to say it, this is America. We've had kids, with gun shootings from high schools in the local high schools. So, these are dirty wounds. So you can't keep a peripheral nerve catheter there for a long time. So we had a kid recently where she, came in with strep throat. She crashed onto ECMO because of septic shock. She had all 4 limbs amputated, and it was devastating. And, we tried all our tricks of, stuff, epidurals, single shot blocks, catheters. But this is a kid that, has to be placed on anticoagulation medication. So you couldn't do that. So we tried something that Hesham talked about earlier. We tried a peripheral nerve stimulator for her. And the interesting thing is that the most pain she had was in one limb, and most phantom pain she had in one limb. But when we placed the leads, we used the Sprint device. We placed the leads for 2 months as they recommend. We just placed the lead in one limb, and the pain dropped dramatically in that limb, but as well all 4 limbs. That was the interesting thing that we found. So her phantom pain went away, her residual pain went away, and even when we took the leads out 2 months later, she continues to have no pain. So she's not on any opiates, she's not on any neuropathic medication, and she's back in full spirit. She's ready to start college. She's getting worked up right now to get prosthesis for her upper limbs and lower limbs. So we restored her quality of life. It's just amazing what you can do with neuromodulation. I mean, these are things that the future holds for us. Try neuromodulation for your acute and chronic pain patients. The next tool that we have is cryoablation. Cryoablation used to be a tool just for the general surgeons and the interventional radiologists, but now you can use that for your amputation patients as well. We have one this coming Monday who also had strep throat, septic shock, and she lost her foot. So we're going to do cryoablation for her leg, and it's worked for our other kids in the past. So there's a lot of new tools coming out that really can change the future of our patients in the long term. So that's 2 tools. The third tool that I actually was surprised by is that I'm using we get consulted for chronic pain for like sickle cell kids. So we're trying a device for vagal nerve stimulation. And vagal nerve stimulation has been used commercially for migraines, anxiety, but those devices, they just put them like that, and they take them off. The one we're using actually, is just like an EKG lead. It targets the auricular nerve of the vagus nerve. So it actually targets, cranial nerve 10. We have found that my friends at Emory have used it for fibromyalgia. They have used it for rheumatoid arthritis, and it's worked well for them. And we're now trying it for our sickle cell kids, and we've seen, drops in pain scores and opiate usage. So, there's a lot of new tools that we can use from the adult world and bring it to peds. So I encourage everybody to, think about these new tools. I mean, we are great regionalists, and the great thing is these things are, you can place this with ultrasound. You don't need fluoro. You don't need complicated devices. I mean, even cryoablation, there's a portable iovera device that, you can do it at the bedside or, in the OR if you need to, under sedation. So that's my answer to Ed about, what excites me. That is really it. And Hesham, touched on a lot of topics related to peripheral nerve stimulation. That is what we're trying to do in our peds world now.
Thank you so much for all of those information. Those really helpful. I think to make it more interactive, I'll invite questions to our group. Raj and
So thank you guys. And there was a question from our colleague, Jerry Jones. He said, how do you explain to kids the numbness and weakness they will feel after the block?
Can I answer that?
sure.
Okay, so one way we kind of deal with this is kind of use words that they understand. So I typically explain to my patient and the caregivers, because often these kids go back home, that your maybe, say for example, the foot after a sciatic block, that your leg is going to feel a little sleepy. And as it wakes up, you might feel some tingling. It's like, you have something, zapping your leg. It's very normal. And one thing we have done is moved away from doing concentrated solutions, because that gives a very uncomfortable kind of dense block, almost like a dead body part, which is very difficult to explain to a lot of children. So we typically do blocks with 0.2% or 0.1% so that the transition is gentler. And when we do catheters for especially our kids who go home, those are teenagers who go home with lumbar plexus catheters or adductor catheters. Again, we've tried to limit our practice to 0.2% because all our patients get general anesthetics. So the transition is not quite as obvious. Does that answer?
If I may add to it too, I think there's a difference between prepping your patient for a single injection or single shot block versus a catheter. And so for a single shot, either one really, I think communication, like Rani said, is it's hugely important both for parents and for kids involved. But I think one aspect that we often maybe underestimate is that even when we're dealing with kids, we often take a very paternalistic approach. But it's if you think back to when you were a child, like things just kind of happen to you, and it feels really like your body's not your body when people are making decisions for it. And I think the same approach for adults, but like kids are the same way. Like it in catheters especially, it's nice to involve a child. Like, hey, how are you feeling? Do you want to like feel your leg or your arm a little bit more than you are right now, or would you rather have it be less painful? And give them that option. So that they can be a little bit more in charge of their bodies and their experience. And I think that is so empowering to them, and that really changes how they can cope with what they're going through, whether it is pain or numbness or any other sensation.
One thing in my institution, what you do is we have involved the child life in a part of a team. So for me, when I finish my first case, then I go and see the patient, talk to them, and come back. But the patient is already here 2 hours prior to the surgery, and all this time they spend with the child life person who plays with them, talks to them in their own language, and that actually helps. And they explain the nerve block a bit more. Okay, this is what is going to happen in a more friendly ways with virtual reality, toys, and different things. So, and before me coming and speaking to them, they're already prepped with the child life, and the families are also prepped by the surgical team when they come to visit the clinic. But the child life actually plays a big role in us in helping preparing the child.
We are actually lucky that we have we have a pain psychologist who comes and talks to the patients, and that really helps them, see how their emotions are doing, and work with them to feel better. So, if you have that resource, that's amazing.
Yeah, I think having child psychologists is really nice, and it's a huge advantage in children's hospitals. But like children also go to non-children's hospitals, and so if you don't have those resources, I think just think back to when you were a child yourself, or if you have kids, like how would your kid respond to you? And oftentimes we find ourselves being like talking at the child, or like talking a little bit differently. I think kids can see through it. They know when we're faking it. And so if you're just your genuine self, I think it's a lot more authentic and approachable and believable, really.
Yeah, and co-opting surgeons, because they're the ones who first introduced the block. So having a good surgeon on the team who actually explains the story. And then often these kids come back again and again. So they themselves are advocates. So a lot of my patients tell me, last time it was too dense, or can a block that is more dense? So yes, so I think we should credit them to be individuals, and also have a strong surgical team and child life, as my colleagues pointed out.
Okay.
Rakesh, do you have a question, or I have another one if you want me to go next?
Just a good audience here.
Yeah, I was my comment to the question about the numbness. I don't take care of young pediatric patients, but in our ambulatory center, like Stephanie said, that we do get teenagers and stuff in a non-traditional pediatric space. And I find that for those teenagers, there's something about the age group between like 13 and like actually closer to like 14, 15, and 24. And it's in young men that if their arm is numb, but it's in a different place than where it fell asleep, they freak out. So like if they're getting a shoulder done and it's going to be in a sling, but they fell asleep with their arm by their side, that really messes with their head. So I always try to put their arm in the position that it's going to be at the end of surgery. And for some reason that doesn't create as much like psychological dissonance for them, and they don't freak out quite as much. But that's just my own little
No, that's
quirk.
true though. That's a very interesting comment, but we face that every time.
Yeah,
Kind of every day.
it's that separation of the like where they last remembered it and where they see it with their eyes. It's kind of like when you're on a boat in a cruise ship underneath and you can't see the ocean, and then all of a sudden that makes your inner ear get confused and you get seasick. To me, it's like it seems like it's like a visual seasickness for them, and they get that dissonance. But anyway, a question for you guys again as an adult regional anesthesiologist is, Stephanie, you talked a lot about the safety aspects from the PRAM network and the PRAM network, and doing general anesthesia blocks under general anesthesia. How much of that is translatable to the adult population? Should we just learn from you guys doing pediatric regional under general anesthesia and take the distress away from a lot of our adult patients and do blocks under general?
That's a really interesting question. So I think I talked about the safety component, but there are also other factors within our practice that we also have to balance. So one downside to doing blocks under general anesthesia is it's time consuming. You have to wait for the patient to be induced and then set up to do your block, and then your surgeon is waiting, and the optics just don't jive as well within the whole perioperative system. And so I would say for an adult practice, which I've also done as well, it's way more efficient to just get the block out of the way and pre-op with a little bit of sedation, with really good communication, and have that patient ready to go to the operating room and have your surgeon be happy, because they're your biggest buy-in. You really can't do your block without your surgical buy-in. And so for us, we do it because the patients and the parents and the surgeons respect that it is safer and a more pleasant experience. But I think the same can be achieved by doing it how most of you guys do it on the adult side, which is to do it beforehand.
To plug the question, so if you have a very anxious adult patient, are you comfortable doing those blocks under GA?
I'm
Yes.
100%. Okay, I
Can I answer that?
question.
Oh,
sure.
okay.
Vipin, go.
Let me just, I was in private practice. I did peds and adults. So I took care of the patient from all angles, like the anesthesia and the pain. So in my world, it was actually faster to do it while they were under anesthesia, because I'm already putting them to sleep. And it was very safe. I never had an issue. Actually, I got more comfortable doing blocks in adults under anesthesia, and then I translated that to peds.
And, we take care of 100-kilo teenagers. We do thoracic epidurals while they're asleep. And one thing I want to point out, the disadvantage of doing blocks under anesthesia is you have to remind the anesthesiologist at the head of the table not to do a paralytic if you want to use a dual mode, like ultrasound with nerve stimulation, like when you do subgluteal sciatics or you want to do lumbar plexus. So that could be a huge limitation.
Like my practice, like I practice, Rakesh knows, we have a pediatric hospital within a bigger adult hospital. So I do a bit of adult regional anesthesia as well. And I'm happy to do the block when they sleep. No, like we have breast cancer program. And these patients some of them young breast cancer patients are really devastated, psychologically depressed and all. I'm not going to poke them 3 or 4 times. I'll rather do the block when they sleep. And I have good results from them. Same thing, very often we have hip fracture patients who are in the 80s, 90s, who are already cognitively declined. So we're doing a similar thing. So it'll be difficult for me to poke those patients awake because there's so much of cognitive decline and moving a lot. So we put them to sleep and do the block. So I'm happy with my knowledge from pediatric to translate that in adults and do it unless it's a surgical block that's needed.
So for us, we have a checklist modification. We always, if there's a regional involved, the checklist defaults to, do you want to do paralytic? So the nurse asks that even before we induce. So the team is prepped, and we actually, again, page the anesthesia team to let them know again. So there's a double and a triple check to remind them, hey, no paralytic, you can intubate with maybe large dose propofol or remifentanil or succinylcholine. So yeah.
Yeah, my shorthand for this is that if I'm dealing with an adult, if it's a fascial plain block, I'll do it in under general anesthesia anytime. That's a chip shot. But if it's a peripheral nerve block, if the adult is going to act like a child, then they'll get a pediatric regional, which is under general anesthesia. So that's the simple version of how I interpret the PRAN network. is I just take that information and carry it over. And if they can be, and even if, and I've had teenagers that can act like adults, and then I'll do it awake. I'll do the blocks while they're awake under sedation, and I'll usually just ask them at that point. So I've had it both ways. Yeah. Well, I want to thank you guys. We have had, this has been a great panel. I really appreciate all of your guys' insight, incredible knowledge. Pediatric regional, it's this conversation I've been hearing about for the last decade, and it's just accelerated over the last decade, and it's exciting to see that children are having better options for pain management, both chronic and acute pain, and for perioperative care. So you guys are really leading the charge on that. I really appreciate all of you guys being here as part of the World Day of Regional Anesthesia and contributing this. Thank you so much.
Thank you all for inviting us.
Fantastic job organizing as well and inviting us.
Yeah.
Well, thank you guys. Have a great day.
Thank you. Bye.
Thank you, team.